just call out my name, and you know wherever I am, I'll come running to see you again. Winter, spring, summer or fall, all you have to do is call, and I'll be there. You've got a friend. If the sky above you grows dark and full of clouds, and that old north wind should begin to blow, keep your head together and call my name out loud. Soon you'll hear me knocking upon your door. You just call out my name, and you know wherever I am, I'll come running to see you again. Winter, spring, summer or fall, all you have to do is call, and I'll be there. Now ain't it good to know that you've got a friend? When people can be so cold, they'll hurt you and desert you and take your soul if you let them. Oh, but don't you let them. You just call out my name, and you know wherever I am, I'll come running to see you again. Winter, spring, summer or fall, all you have to do is call, and I'll be there. You've got a friend. 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 I want to spend my life with you. Let me say that since we've been together, loving you forever, ooh, is all I need. Let me be the one you come running to, and I'll never be untrue. Let's stay together, loving you weather turns a good or bad, happy or sad. Why people break up, and turn around and make up. What I just can't see. You'd never do that to me. 'Cause being around you is all I see. let's stay together. I'm loving you whether times are good or bad, or happy or sad. Let's stay together. Loving you whether times are good or bad, or happy or sad. Good or bad, or happy or sad. Good or bad, or happy or sad. Want to, but I can't help it. I love the way it feels. Just got me stuck between my fantasy and what is real. I need it when I want it. I want it when I don't. Tell myself I'll stop every day, knowing that I won't. I got a problem and I know what to do about it. Even if I did, I don't know if I would quit, but I doubt it. I'm taken by the thought of it, and I know this much is true, baby. You have become my addiction. I'm so strung out on you, I can barely move, but I like it, and it's all because of you, and it's all because of you. And it's all because of you. And it's all because never get enough. She's the sweetest drug. Think of it every second. I can't get nothing done. Only concern is the next time gonna get me some. No, I should stay away from, 'cause it's no good for me. I try and try.
Boa noite a todos, sejam bem-vindos a mais um evento com parceria da CIED e Uniseg. Sou o Marcelo Piazza, da M Piazza Produções, empresa responsável pelo operacional do Zoom e as traduções em inglês, espanhol e português. Para uma boa visualização da reunião, é importante estarem atentos a alguns detalhes que são: ter uma boa conexão da internet, desligar todos os aplicativos no computador ou celular, deixando apenas o Zoom aberto, acessar o Zoom apenas pelo aplicativo e não pelo navegador, pois pelo navegador as opções para os idiomas não aparecem. Para o acesso pelo computador, clicar no globinho redondo abaixo à sua direita para escolher o idioma da sua preferência. Se for no celular, clicar em mais, logo abaixo à sua direita e em seguida em idiomas. Para dúvidas técnicas, enviar mensagem de chat solicitando suporte. Para perguntas, utilizar o campo de Q e A. Muito obrigado e tenha um bom evento.
Welcome. Welcome to our first event tonight, our joint event between NYSGE and CIED. To all of those joining us, we'll review the instructions that were just given as well when we go over the slides. But I would like to say bienvenidos a CIED y bienvenidos a CIED y un abrazo enorme de NYSGE. We know this time has been difficult over this past year, but with challenge, we have opportunities to really grow and to celebrate the friendships and partnerships that we have been building all along. And it's really wonderful that we can all come together in this virtual way and celebrate the fact that we are neighbors. We here in New York and NYSGE think that we are your direct portal to the US, and we look forward to having this get together and many more like it. And to our NYSGE members, this is the first event that we are having with multilingual transmission. And we really hope to use this opportunity to honor the diversity of our members and our patients, and to be able to provide better care for them, as well as to provide our needs to our growing members. I look forward to seeing you all, hopefully virtually in December during our annual course. With that, I will pass it over to Carlos Eduardo Oliveira from CIED.
Obrigado, Anrita. Bem-vindos a todos. É um grande prazer fazer esta parceria e tenho que felicitar essa iniciativa de Anrita e de nosso presidente Assador. Espero que este seja apenas o primeiro evento conjunto entre as duas sociedades. Para dar andamento ao evento, eu gostaria de apresentar os dois convidados da CIED, que são o Dr. Lix Alfredo Reis de Oliveira, do Brasil, professor assistente da Unidade de Endoscopia e Coloproctologia da PUC de Campinas, Brasil, e o Dr. Kermit, que é membro da Associação de Gastroenterologia de Porto Rico, membro do Comitê de Qualidade em Endoscopia da CIED e ex-presidente da Sociedade de Endoscopia Terapêutica de Porto Rico. Devolvo a palavra a Anrita.
Thank you. And now I will hand it over to our two NYSGE course directors, Hila Sunse from Mount Sinai in New York, and Juan Carlos Bucovo from Stony Brook, New York. Thank you and enjoy the night.
Thank you, Amrita. Thank you, Carlos. And thank you, everyone, for joining us. So, Gil, if you could start off, we'll have the introductions of our first talk.
Okay, today, as you might have seen from the program, we're going to be talking about colon cancer screening, one of the most important jobs of the gastroenterologist. I'd like to introduce my colleague and good friend, Dr. Lincoln Hernandez. He graduated from the Universidad Nacional Pedro Enrique Ureña in Santo Domingo, and he came to New York, did his GI training in Tulane, in New Orleans, and now he's an assistant professor here at Mount Sinai in New York, working with a big Latino population in Washington Heights. So between Santo Domingo, New Orleans, and New York, I think that Dr. Hernandez has the experience to tell us about his tips here for getting people prepared for colonoscopy. So Dr. Hernandez, por favor.
All right. Hi, everyone. Thank you so much for the introduction, Gil, and thank you to the coordinators of this event. I'm going to go ahead and just play my presentation here. Let me just see. Yeah. All right. Can all right, so let me see if I can make this work. Okay. So I just wanted to make sure that my screen is visible there to everyone. So the topic that I was assigned, as you can see from the title of it, it's quite ambitious. It's the basis of colonoscopy, the who, what, where, and why. And it's a little expansive, but what I'm going to try to do is try to narrow down to the reality of what's been happening in the last few years, as well as what's happening now in the practice of the gastroenterologist, with a focus on colon cancer screening, and obviously focus on the colonoscopy, which is the methodology that we are all experts in. This is kind of like an overview of this presentation, and I'm just going to go over a quick background on colorectal cancer, CRC, and the effects of screening on this entity. The WHO, which is basically who are we screening, what is the population at risk, and what is happening recently. There is a change in the, shall we say, in the game here that has been noticed. The other topic will be the what, which is the choosing what type of screening methodology we'll be using. Where we do practice this procedure in the United States, and why? I mean, why is this something that we use with such proficiency and such and so often? We're going to go over its efficiency, safety, and cost effectiveness. And then lastly, I'm just going to talk a little bit about current challenges and how we can overcome them. So without further ado, I'm going to start with the what we call population at risk, which is the people that we screen. Colorectal cancer is the fourth most common diagnosed cancer in the U.S. It's the second leading cause of cancer. We expect that this year about 50,000 deaths, and that's pretty much the number that we have. And CRC, the disease burden that it has varies across races. So if you can look at this slide right here, the African Americans, the Indian Americans, and the Native Alaskans are represented in incidence and mortality there in the columns that are red and purple. And these are the highest, both in incidence and mortality across the board, men and women. So it gives you an idea that this disease varies across race groups. And we're going to get a little bit into that as we move along in the talk. Just give me 1 second here. Let me see if I can get rid of this. Perfect. So the incidence of colorectal cancer and the trend has actually declined since the year 2000. And it's specifically more in patients that are above the age of 55. So the decline has been throughout the decades. But the reason I mentioned the year 2000 is because of the fact that before the year 2000, what we believe that the reduction of risk was caused mainly by changes in habits, decreased risk factors like less red meat, less cigarette smoking, more aspirin use. But after the year 2000, this reduction in incidence has been mostly attributed to screening, effective screening, improved therapy, and they both have contributed to a decline of the incidence of this disease. There's been a drop in about 32% from the year 2013, and particularly in distal tumors, and particularly in the population above the age of 65. However, by contrast, adults younger than 55 have had a change that it's opposite to what we have seen in the older patients. From 94 to the year 2000, the incidence has increased by 51%, and the mortality has increased by 11%. And this has solely been based on distal tumors and rectal cancer. So that's an observation that we've had. And then at glance, the whole summation of our efforts with this disease can be seen in this Sears stats, basically a population-based analysis. And the 5-year relative survival of colon cancer with everything that we've done is about 65%, as you can see there. The new cases are estimated to be about 150,000, and 8.2% of all the cancers diagnosed in 2020. The estimated deaths is going to be about 50,000 in this year, 53,200, as you can see there. And the percentage of all cancer deaths is about 9%. And if you can see this graph here to the left, you can see the decline of incidence and mortality that has been gradual since the beginning of the 90s. And to further elucidate this, you can look at this graph that was published in 2017, and it's basically a serious population analysis. And you can see to the far right there that the age above 65 has had a drop in incidence and mortality. So this is the effect that we wanted when we started working with doing colonoscopies in these patients and flex-6 and everything that we have been doing since the beginning of time. There's a similar effect you can see in the middle when you see both columns of women and men's incidence and mortality have dramatically dropped throughout the years. But if you go here towards the left, you can see the 2 arrows pointing in upstream direction of incidence and mortality, both in males and females, in younger patients, in the population between 20 and 49 years of age. This is a pattern that is has been observed, and we don't know why this is happening. We looked at multiple issues, risk factors that have increased in modern life, like sedentarism, alcohol, obesity, a high BMI, and things in the diet. All these things have been looked at, but this is an actual real increment in incidence of mortality in younger patients. And we all have these patients, right? We all have this 25-year-old that came in with bleeding, or 30-year-old that came in with rectal bleeding, and we do a colonoscopy and this person has cancer, no family history. And these patients are ending up having an increased mortality. So we're seeing this in the population analysis as well as in our practices. And this is a little bit of a more decade by decade graph in a cohort basis. As you can see, this is the incidence and mortality. There is a drop as we go along with the decades in the year and in the older patients at the top of the graph. And if you look at the very bottom, there is an surge of patients. And in the younger years, so 20, 25-year-olds, we're seeing this both in incidence and mortalities. And the colorectal cancer statistics that were published recently by Siegel, which is one of the groups that are really doing a lot of work, have been doing a lot of work on this. They just showed there's a 12% increase in CRC in patients that are less than 50 years old. That's been proven. There is a 2% increase in the incidence in all anatomical sites. And the mortality has also increased in this population. When they did further analysis, they realized that this is something that we knew that was happening in African Americans, but this is also happening in non-Hispanic whites. It is largely based on white patients in the population. A further cohort analysis of the actual time in which people are born was also interesting. And basically adults born around the year 1990 have statistically twice the risk of colon cancer and 4 times the risk of rectal cancer compared to adults born around the year 1950, which is the ones that have the lower risk in this population. So the question that we have is, everybody's mind is, well, is it because we're doing more testing, we're doing more procedures, there's more available colonoscopy equipment and providers and all that, and that has been actually debunked, right? The American Cancer Association basically has looked at data, and patients that were diagnosed with colon cancer where they were less than 55 were analyzed, and they realized that the screening rate for patients between 45 and 49 has actually doubled in the last 3 years. And the screening rates between patients between 40 and 45 has remained the same. Yet the incidence of cancer of advanced disease is relatively the same. If anything, is even more in the younger group, the ones before the age of 45. And that goes against the theory that if we do more testing, more colonoscopies, we find more. Because the same phenomenon that we see in screening efforts for the older patients, those above the age of 60, 65, should be happening with younger patients, which goes against what we call the detection bias. And this graph right here is an interesting graph. This is one of my colleagues from Tulane. Jordan Carlitz published this last year. He actually presented this at the DDW in San Diego last year. And I mean, this is a fascinating and compelling graph, and that's why I put it here, because when he did the study, he realized that most of our analysis and our population analysis were based in blocks, brackets, 40 to 50, 40 to 45, 45 to 50. So what he decided to do is to dissect even further and just go by year, by 12-month blocks, by the month. And this is the age of a diagnosis and their incidence. And you can see that if you go around age 48, 49, there is a bump, an actual sharp uptake of diagnosis of an advanced colorectal cancer. And this could be explained by, initially when we look at it, is, well, okay, it's probably, this is when colonoscopy screening starts at the age of 50. However, this can also be looked at, and data supports it, that it's more a result of earlier disease as the natural progression of advanced adenomas start around the age of 40, 45, and then this is when they end up having colorectal cancer. So this is a compelling analysis of the behavior of the disease, and this is what pushes more towards the screening that we do to be done at an earlier age, not at 50, but starting at age 45. So let's just go back to where we got all this, right? And the reason this is important is that we need to know how we get how do we get here in order to continue to offer this as an option to our patients. The initial guidelines done by the ACS, the American Cancer Society, were in 2008. And this had a combination of a multi-society effort along with the USPSTF. And this is the classic recommendations that we all do follow and have been doing for years with our patients. Start screening at the age of 50. This was revised again in 2016 by the by the task force, the United States Parental Services and Task Force. And it was reaffirmed that further recommendations were given to screen adults from the age of 50 to 75 and adults from 76 to 85. We could do it on a case-by-case individual basis. So those were recommendations that we've been following. But between 2008 and 2016, something dramatically important happened. And it's basically the Affordable Care Act. So the Affordable Care Act put it into law that we will need to screen patients based on recommendations from the USPSTF. So this is what became law, and evidence of higher screening leading to higher detection and decreasing mortality happened both in colon cancer and in breast cancer. So the ACA, the Affordable Care Act, actually helped the implementation of these recommendations. And I wanted to mention this relationship between the law and our recommendations, because it matters when we convince our patients and convince our population to get screened, because they want to get covered. Obviously, insurance is a big factor here. And if you don't have coverage, just people are not going to adhere to our recommendations. And that's been proven time and again. In 2017, a multi-society task force was put together, and they published some additional recommendations, including starting colonoscopies at the age of 45, but these were a little bit weak and low quality of evidence. However, the ACS that had a revised effort of their guidelines in 2018. And I wanted to point this out because it's right in the center of the graph, because it is key that we all figure out how to get an hour of our time and read these guidelines, because they were done. It was a huge effort, and it was an effort that was made in conception to be transparent. They decided to have what they called a guideline development group that included general practitioners, epidemiologists, biostatisticians, economists, and actual patients representatives. It was funded all by the ACS, and they developed recommendations that were based by running models that have been used by the USPSTF in the past. And these are the models that we've used since 2008 and before, But yet in 2018, these models proved that the recommendations for colonoscopy at the age of 45 were the way to go. And they labeled this in a grading system as a qualified recommendation. Now, a qualified recommendation is basically something that has statistical, clear data that demonstrates its benefit or harm, but the consensus of benefit-harm ratio has not yet been established. But there is clear data and is the basis of that recommendation. So they focused on something called life year gain. And they also included like the burden on patients and a bunch of stuff that made this a robust analysis. And for the first time, they recommended an actual time to stop colonoscopies. As you can see there, they recommended beginning at 45, continue through the age of 75, and after that, individualize, which is not that different than from before. But they actually recommended to stop at 85. All the data they analyzed just pointed to the fact that it's probably not worth doing, and you should probably discourage patients after that age, which is a clear recommendation that we never had. Now, we fast forward now here to October 27, 2020, and the USPSTF task force actually started giving some signs that they were up to finishing up with their second review. This is a screenshot from my cell phone that I got from a patient, an actual patient that just happens to be a friend of mine, that I had a clear discussion with him on recommendations on screening. And this person is 44 years old and he wanted to get screened. And he saw this in the Wall Street Journal and he sent it to me. So the USPF is still delivering this. It's going to be released soon. And the reason I am mentioning this is because, remember, as I mentioned at the beginning, this is enforced by the Affordable Care Act. And after all this journey of recommendations and these observations on higher risk in younger patients, tomorrow the Supreme Court will hear arguments on whether the Affordable Care Act is constitutional or not. So it gives us a little bit of sense of an irony that we are getting to the point in which these task force recommendations will be published, and yet the livelihood of the law that sustains all this effort is in question. So I'm going to move on and just go to the what. And it's basically, how do we choose? And I don't want to spend too much time here. I think that if you look at all the guidelines that have been published, there's a separation between stool-based tests and visual structural tests like colonoscopies and Flexic and CT colographies. The guidelines published by the ACS basically mentioned 6 recommended screening tests: the colonoscopy, the CT, the flexible sigmoidoscopy, which still has good data, the FIT test, a high sensitivity guaiac test. I'm saying high sensitivity because there's a bunch of out there, but there's likely only one that really has been proven to work, and also the multi-DNA test. So for stool-based tests, the FIT, they recommend it every year. For the OFB, they recommend it every year also. And for the multi-targeted DNA testing every 3 years. So we can go a little detail in that maybe on the question session, but those were the recommendations based on the data. The structural examinations were colonoscopy, CT colonography, and Flexic. So, and there were 10 and 5 and 5 respectively, as far as the years in which they should be done as in regards of intervals. All of these tests demonstrated live year gains and demonstrated efficiency and decreased mortality, decreased incidence, and increased survival. So this is what we have available, and it all depends on the setting. It all depends on patients' preferences. But definitely there's something to say about what do we do with all these tests? I mean, what is it that we should recommend, or in general practitioners, or the healthcare system in general? And it's been looked at, and then a study in 2012 looked at offering colonoscopy versus stool test versus both. And they realized that the adherence was higher if you offered patients a choice between the two, as opposed to offering one versus the other. And obviously you can't offer them both because it just leads to confusion. But colonoscopies, the adherence was about 38%. The guaiac was 66%. And if you give the patients the options of the two, it went up to 68%. And, no single test is preferred by the patients. And the intention to screen is higher if the test is consonant with the patient's preference. So our efforts and the efforts of the ACS guidelines, and that's why, there weren't any gastroenterologists in those guidelines, is because we should be able to offer the patient the options for the purpose of increasing adherence. And when we look at this, in full disclosure here, I like doing colonoscopies. This is our life. I like it. This is our livelihood to most of us. But at the end of the day, if they don't adhere, you can't get them in. The recommendations it's a lot of work, and you really don't get the results that you want. So there are tools that we can use, and this cancer.org #colonMD from the ACS has specific instructions on how to convey that information to patients, and is geared towards clinicians as well as the general population. Now, the key to offering options is the following. The appropriate follow-up to a positive non-colonoscopic test, any stool test that you do, or any CT colography that you do, this is to be followed by a timely colonoscopy. When I say timely, the recommended time is about 7 to 9 months tops. Reason being that after 10 months, there is an increased rate by 48% of colorectal cancer. Let me just move on here, and then, so now the next step would be I'm in trouble here, the where, which is where we practice these tests, the colonoscopy, basically in the United States. So these are the 3 sites that we have. We have a historical site, which is the hospital, and it was a monopoly since the beginning of time until the onset of ambulatory surgery centers. And the third location in which these tests are done is just the basic medical office. The basic medical office is a little challenging given the comorbidities and the higher rates of sickness that our general population is having. And you need staff and support that you may not have there. So that's why the ambulatory surgery center and hospital are pretty much where most of these tests are done, specifically in the ASC. But the ASCs are basically a result of medical economics and healthcare economics. But currently, this is where most of the colonoscopies are done in the United States. These ASCs are controlled by CMS guidelines. They report data, they report quality in order to sustain accreditation. So these are more robust in infrastructure than the office. And they are basically something that has saved money to the government, given that they charge a fraction of what a hospital would do. Plus, they're more efficient, there's less waiting time, and there's the patients like it a little bit more than the office, than the service, than the hospital may offer. So those are the 3 basic settings. The first ASC was in 1970, so this is something relatively new. But by the year 2000, 70% of all surgeries were done at the ASC level. And this is increasing since then. It hasn't stopped. These ASCs, the ones that are dedicated to, which are, in general, the more rooms you have, it doesn't necessarily mean that you do more procedures, except in gastroenterology. So one room, 1,000 patients results in an increase of 1.8% in colonoscopies. And they have actually saved money because they decrease Medicare spending. So as a result, most of our tests are done in the outpatient setting. So the question is whether it's safer to do it in a hospital or safer to do it in the ASC, and that's been looked at. There is a median risk standardized of unplanned hospital visits that was analyzed. And you see in this graph here to the left, this is the comparison between ambulatory surgery centers and hospitals. And the rate of non-planned hospitalizations at the first week after the colonoscopy is about 10.2%. I'm sorry, 10.2 per 1,000. So they're relatively the same as far as risk standardized analysis. And as a result, 90% of our colonoscopies are done there. Now, why do we do colonoscopies here? I'm not going to go too much into this because my colleagues are going to be working a little bit more on this, but definitely it's something that has the data. There's this RCT data that there's experiences for the last 20 years that we have dropped the incidence and mortality of the disease. There is some cons, the cost is still there, the burden to the patient with the prep and taking time off work and having a chaperone. The quality of the procedure is based on the performance. It's dependent on the performance upon the adequacy of quality measures. So this has to be subject to a standardized measurement of quality in order to make this effective. Otherwise, it doesn't work. And then just to continue, why we're doing colonoscopies is the most frequent used CRC screening modality in the US. The sensitivity goes from 75 to 93%. The specificity is 94%. It's a good test. It saves lives. And in the USPSTF models, it actually was superior to the other modalities that we mentioned in previous slides. So it saves more, it gives more life year gains. And in the models, there was a 62% reduction in incidence if we continue to do this. And it averts 22 to 24 deaths per 1,000 screenings. And if you look at this little graph here, I'm circling that there is a subtle but a higher effect on colonoscopy when compared to the other screening modalities. It's subtle, but it's real. Unfortunately, not everybody gets screened. That's due to many limitations. And for those limitations, I'm going to mention a few because I'm running out of time here. But we're at about 60% nationwide on people to get screened. And there's multiple barriers. There's access, payments, how uncomfortable this is to some patients. There's cultural sensitivities that are there. And that has been expressed in many trials. But when you look at the Hispanic population, which is the population that we deal with up in Northern Manhattan, in New York City has had an effort to increase rate of colonoscopies, and that's been a law passed for the last 10, 15 years that comes from the state for the purpose of increasing colonoscopy rates. And our disparity in Hispanics, it's about in the middle, as you can see there from that graph. But if you go throughout the nation, you can go up to 14.2 to 33.9% in disparity between Hispanics and the rest of the population. This speaks volumes in access as well as coverage. And these are just some take-home points. Just to summarize this, the CRC in adults should be done at the age 45 all the way through 75 via stool or visual exam. And it depends on the preference as well as the availability. It has to be adjusted to the reality of where you were located, but it has to be done. And regardless whether you do a stool versus a visual exam, it should be followed by a prompt colonoscopy for the purpose of removing an adenomatous lesion or staging or diagnosing a cancer. So these modalities are interconnected, and the common denominator is the colonoscopy. It is still the gold standard. Offering choices is better than just mandating the patients to do something. Just give them the choice. That's been proven. And in our experience, we've integrated a multi-level system. It's not just me, my medical assistants, nurses. We do mail, we do calls, we do text, and we have 2 recall systems that we implement in order to make patients not only adhere to the screenings, but also adhere to the surveillances. And what we noticed that has worked for us is to have a culturally sensitive approach. So, our staff is really part of the community. And it not can only engage culturally with our patients, but also engage in the level as a provider, which is something that we have used. And we think that has been the key to our success in our practice. And then, all of this is based on government level research and applications via the law. For example, the ACA cost sharing elimination helped people get access and prove that you can increase rates of screening. And tomorrow, the Supreme Court will listen to this case, and we'll see what happens. I mean, after all, this is 2020, so no one knows what's going to happen, right? And thank you.
Great. That was a wonderful job, Lincoln. A lot of information there. Population information, socioeconomic information, very comprehensive, and a lot of information to digest. I think we're going to save some of the question and answer until the end, but while we're here, I would like to acknowledge and give thanks to our friends from Nestle. Nestle Health Science is now in the gastroenterology space and has helped to support this presentation today. So we appreciate them very much for that. They're not just in chocolates anymore. And from there, Juan Carlos.
Thanks, Gil. And we're going to move on to our next talk. Dr. Carlos Eduardo, if you could introduce your panel. Gracias.
Congrats, Dr. Hernandez, for the excellent presentation. Vou chamar agora o grande amigo Dr. Lix Oliveira. Para quem não conhece, o Dr. Lix é um ícone da colonoscopia no Brasil e na América do Sul. O Dr. Lix falará sobre colonoscopia, o exame, o instrumento, os instrumentos e as técnicas utilizadas para o exame. Dr. Lix, com a palavra.
Boa noite a todos. Eu queria agradecer o convite. Me sinto muito honrado por participar de uma sessão tão fantástica quanto essa e com pessoas que a gente gostaria de encontrar pessoalmente, mas devido a essa pandemia a gente acaba se encontrando virtualmente, mas já é alguma coisa. Queria agradecer a Amrita, o Cláudio, o Eduardo e dizer que o que o Carlos Eduardo falou realmente é pela nossa amizade, eu tenho certeza disso. Eu vou compartilhar aqui a tela. Vocês estão vendo?
Sim, Lix.
Perfeito.
Então, o que me cabe falar é pouca coisa, realmente é tudo da colonoscopia. Então, nós vamos tentar focar em algumas áreas e para tentar passar para vocês algumas coisas. Eu não estou conseguindo... Pronto. Bom, então, como o Dr. Lincoln falou muito bem, o câncer coloretal é o quarto mais diagnosticado nos Estados Unidos, o segundo na Europa e o segundo no nosso país também, no Brasil. E a colonoscopia, como ele mostrou, é o gold standard para detecção e remoção das lesões pré-malignas do cólon. E a colonoscopia, a polipectomia, previne a maior parte dos cânceres. Já mostrado por vários estudos, desde do National Polyp Study, e a gente sabe que é um problema mundial e que, segundo a Agência Internacional de Estudo do Câncer, já mostrou que a gente ia ter uma grande quantidade, 881 mil mortes por câncer coloretal no mundo em 2018. E no Brasil, só para vocês verem como é que está a nossa situação, em 2020 o câncer coloretal ocupa o segundo lugar dos cânceres, tanto em homem quanto em mulher, com uma estimativa de 40 mil casos no Brasil e com uma estimativa de morte da metade desses pacientes. Então, o que nós vamos abordar, primeiro, algumas coisas gerais, mas eu considero importantes, os equipamentos para a colonoscopia atual, as técnicas que a gente faz colonoscopia e a qualidade da colonoscopia e como tratar 90% das lesões na colonoscopia de rotina. E alguns detalhes que podem ajudar numa colonoscopia básica. Nós estamos, infelizmente, vivendo na época Covid. Antigamente, antes do Covid, a gente era muito feliz, a gente trabalhava apenas com a roupa do centro cirúrgico e a luva, e não tinha uma proteção maior. E com o Covid, hoje em dia, a gente demora muito para começar um exame, demora muito para acabar o exame, porque a gente tem que tirar toda essa paramentação de proteção individual. Mas é muito importante o uso dela e eu acho que essa vai ficar para sempre. A outra coisa que a gente tem que começar a se preocupar é como a gente está fazendo muita colonoscopia, o screening do câncer coloretal está aumentando no mundo inteiro. Então, o que a gente sabe é que a gente tem vários trabalhos mostrando cada vez mais que a gente tem muitas lesões de fazer endoscopia, principalmente se a gente não faz a colonoscopia fazendo com uma ergonomia adequada, você posicionando o monitor, posicionando o paciente de uma forma que você tenha um pouco mais de conforto. E a gente tem alguns estudos mostrando que a gente tem 71% dos endoscopistas com lesões musculoesqueléticas. Eu me incluo entre eles. O procedimento ele pode ser sem sedação. Existem muitos que são favoráveis a não fazer sedação. Eu acho que isso daqui, para o que a gente faz no nosso dia a dia, isso é uma opção do paciente. Se ele quiser sem sedação, nós fazemos, mas a maioria a gente procura fazer com sedação. Pode ser a sedação chamada consciente, ou uma sedação profunda, ou anestesia geral. Vai depender da preferência do endoscopista, a indicação do procedimento, se for um procedimento com intenção terapêutica, é lógico que nós vamos precisar de uma sedação mais profunda. A preferência do paciente, a gente deve sempre respeitar a preferência do paciente. Se a gente pode ou não contar com um anestesista no nosso serviço e a parte financeira que, sem dúvida, quanto mais sedação, quanto mais coisa, que a gente utiliza, você tem um procedimento mais caro. E como você pode fazer o procedimento? Até pouquíssimo tempo atrás, a gente só fazia com insuflação do ar ambiente. Hoje em dia, a grande maioria dos serviços utiliza a insuflação de CO2, que ele é absorvido muito mais rápido que o ar ambiente e você não tem o desconforto pós-exame, ou a instilação de água, que você pode realizar também, que é como nós fazemos. Os instrumentos que a gente tem para colonoscopia, nós temos de extensão do aparelho, a gente tem o chamado colonoscópio intermediário, com 135 centímetros, e o colonoscópio longo. O Ocidente prefere o colonoscópio longo e o Oriente prefere o colonoscópio intermediário. Depois nós temos várias modalidades de equipamento que nos facilitam as manobras e principalmente completar o exame. Algumas vezes você tem sigmoides extremamente difíceis de passar, em que você precisa de um aparelho fino até um gastroscópio, você pode ser usado, mas a gente tem endoscópios hoje em dia específicos para isso. E ele pode ter, a maioria dos colonoscópios atuais, ele tem uma variação da rigidez do aparelho, você podendo usar com ele mais rígido ou menos rígido, dependendo do paciente. E a gente tem um acréscimo na colonoscopia. Hoje em dia, a colonoscopia é digital, a magnificação de imagem e a inteligência artificial. Um instrumento, como todos já conhecem, ele tem alguns canais, que principalmente o canal de trabalho, normalmente ele tem que ser um canal de trabalho maior para que a gente possa fazer uma terapêutica com mais segurança. E esse o canal de injeção de água, esse canal é muito importante, principalmente quando se faz terapêutica. A maioria dos endoscópios atuais apresenta esse canal, além das lentes, o sistema de insuflação de ar e água, que também serve para a limpeza da lente. E daí nós passamos a realizar a nossa colonoscopia com maior conforto. Lembrar que, infelizmente, a força que você coloca na extremidade do aparelho não é a mesma que chega que você coloca no corpo do aparelho na introdução, não é a mesma que chega na extremidade distal do equipamento, porque os vetores de força vão se dissipando com as curvas do colo. E lembrar que a gente só tem realmente uma marca anatômica ou duas marcas anatômicas confiáveis, que é o ilho terminal e o seco, com a visão da válvula secal e o osteopendicular. Antigamente a gente achava que esse sinal era super importante, a transiluminação do abdômen pela luz do equipamento. Isso a gente sabe que não tem significado nenhum em saber. Então, se a gente não consegue chegar até o final, você não consegue realizar uma colonoscopia completa, é muito difícil você falar até onde você conseguiu ir. É melhor que você não fale e que você admita que foi uma colonoscopia incompleta. A técnica de colonoscopia ela é muito antiga. O Hiromi Shinya, ele já descreveu isso em 1969, que ele já começava a realizar colonoscopia como a gente faz hoje em dia. E em 73 ele já publicou uma série com mais de 1.000 pacientes tendo sido realizadas colonoscopias. E a técnica que a gente mais usa é 2 mãos com um operador só. Existe a técnica de Tajima, que a gente usa 2 pessoas, uma introduz o aparelho e a outra segura o comando do equipamento. Isso raramente é usado nos dias atuais. E a gente tem 2 técnicas, porque a técnica do Dr. Hiromi Shinya é muito boa, tanto é que não houve evolução da técnica até os dias de hoje. Todos nós fazemos o exame mais ou menos como ele faz, com uma variação ou outra, mas sem dúvida nenhuma seguindo aquela técnica de 1969. E daí surgiram 2 técnicas novas, que foram as novidades: fazer com a técnica de imersão de água, que é a que eu faço, ou fazer com a troca da água. Você aspira todo o conteúdo e injeta uma água limpa. O cólon, a gente sabe que tem uma anatomia, tem alguns pontos fixos do cólon, mas uma grande parte dele não tem muita fixação, e é isso que provoca a formação de alças. Então, a gente tem várias manobras que a gente utiliza, as mais utilizadas são a pull-push e a rotação do equipamento, que isso nos facilita muito a introdução. Então, uma mão, normalmente a mão direita, introduz o equipamento, faz essas manobras, e a mão esquerda trabalha os comandos do equipamento. Nós temos a anatomia do cólon, infelizmente ela muda de paciente para paciente. Graças a Deus, a grande maioria jovens apresenta esse tipo de cólon, que é um cólon bastante fácil de fazer o procedimento, mas existem alguns cólonos mais complexos em que a gente precisa realmente negociar a passagem. E, sem dúvida, o ângulo mais trabalhoso na maioria dos pacientes é o reto sigmoide. E daí nós temos várias manobras para não ter esse movimento paradoxal ou para que a gente consiga retificar. Então, aqui seria a alça mais comum que se forma no equipamento, que é no cólon sigmoide. Graças a Deus, essa é uma alça não muito usual. E daí nós temos a manobra alfa, que você traciona o aparelho e roda ele à direita no sentido anti-horário, fazendo um pouco de pull-push, e você tem a retificação e consegue prosseguir o equipamento. E o reverso da manobra alfa também pode ser usado. A manobra alfa também foi descrita pelo Dr. Tajima. E aqui você tem outras manobras que você pode utilizar, como a aspiração de ar, a pressão abdominal, principalmente nos cólons transversos muito longos, que você pode comprimir com a mão, fazendo com que você tenha uma retificação do aparelho e consiga prosseguir. E lembrar que, normalmente, com o aparelho retificado, a gente atinge o seco com aproximadamente 65 centímetros. Isso na grande maioria dos pacientes. E quando você tem o cólon retificado, você tem um exame muito mais adequado e você tem a introdução no ilho terminal de uma forma mais adequada também. Lembrar que o cólon é perigoso e que faz parte da técnica, principalmente a chegada no seco. Hoje em dia já não é, graças a Deus, mais tão problemática, mas a retirada do equipamento é uma técnica que merece muita, muita atenção, muito cuidado e um mínimo de 6 a 7 minutos. Lembrar que um dos maiores problemas que a gente tem é uma hiperinsuflação de ar. Quando você faz a insuflação de ar, aqui está muito bem representado nesse livro do Dr. Tanaka, quando você tem o cólon sem insuflação de ar, o cólon, a curvatura dele é mínima. Quando você insufla o ar, essa mesma curva, ela acentua e você vai ter muito mais dificuldade. Então, já a grande dica é não insuflar muito ar na introdução do equipamento. E daí, como eu disse, a gente usa essa técnica de imersão em água desde 1992, a gente mandou isso para o DDW em 2010, e a gente tinha o mesmo número de detecção de adenomas, a sedação é um pouco menor, você poupa o paciente de uma sedação mais profunda, e os pacientes eles têm muito conforto com a realização dessa técnica. E isso realmente mostrou em todos os trabalhos que a técnica de insuflação de água ela tem uma diminuição da sedação. O anestesista, se for com anestesia, ele fica muito mais contente com essa técnica do que com a técnica habitual. E se você usar a Water Exchange, você tem aumento da detecção de adenomas e aumento da detecção de adenomas por paciente. Lembrar que as lesões no cólon a gente classifica hoje em dia, desde a classificação de Paris, as lesões polipoides do tipo 1, que são os pólipos pediculados, 1P ou 1S, e as lesões não polipoides, que são as superficialmente elevadas, do tipo 2A, as totalmente planas, do tipo 2B, e as com discreta depressão, do tipo 2C. Não entra na classificação de lesão precoce no cólon as lesões escavadas. Toda lesão ulcerada no cólon, ela já é avançada. E lembrar por que é importante essa classificação, porque as lesões deprimidas, elas têm uma taxa de invasão da submucosa muito alta. Então, é mais ou menos essa divisão das lesões. Os japoneses dividem um pouco diferente por causa das lesões de crescimento lateral, e aqui representado, então, as lesões 1P, 1S, as lesões 2A, a 2B, as lesões do tipo 2C, que são as mais preocupantes, e as lesões de crescimento lateral, que pode ser a granular homogêneo, a granular do tipo misto, as lesões planas, não granulares, totalmente planas, e as lesões com pseudodepressão. E, então, essa é a divisão que se mais utiliza hoje em dia, apesar de agora já haver uma subdivisão da granular homogênea, mas nós não vamos entrar nesse mérito. E lembrar porque a gente também tem que saber dessas divisões, porque as lesões com nodular mista, elas têm uma taxa de invasão de submucosa maior, e as lesões pseudodeprimidas são as mais invasivas da submucosa. Então, elas merecem tratamento diferenciado. Aqui mostrando as lesões, a granular homogênea, essas lesões, elas eventualmente não precisam ser ressecadas em bloco. Essas lesões, os japoneses já admitem que elas só devem ser ressecadas em bloco, mas nos ocidente a gente pode, às vezes, ressecar em fragmentos, desde que se tire o fragmento com nódulo maior num bloco só. As lesões planas, totalmente planas, e as lesões deprimidas, que também apresentam uma característica de invasão da submucosa maior. Não esquecemos dos adenomas, dos césseos serrates, das lesões serrilhadas césseis, desculpa, que também são uma causa do câncer importante de 15% a 20%. Mas a colonoscopia não é perfeita, a gente deixa de ver adenomas até 11%, adenomas de todos os tamanhos até 22%, e deixa de ver câncer, tendo a incidência do câncer de intervalo. E a gente sabe que quanto mais adenomas a gente detecta, a gente diminui a chance de um câncer de intervalo em 3% e a chance de um câncer de intervalo fatal em 5%. E lembrar que o endoscopista sem uma formação adequada é um fator independente para você ter o câncer de intervalo. E, infelizmente, o volume de colonoscopias, per si, ele não aumenta ou não diminui o seu câncer de intervalo. Então, o câncer de intervalo varia muito de local para local. Nós não temos, no Brasil, o nosso índice de câncer de intervalo, infelizmente, mas ele não deve ser pequeno. E sabendo que a maioria dos cânceres de intervalos são lesões que a gente pode prevenir, que são pólipos não vistos, principalmente os planos ou deprimidos, as lesões serrilhadas césseis, ou às vezes você tem um câncer de intervalo por um follow-up inadequado e por remoção incompleta das lesões. E apenas 14% são as lesões que crescem rápido. Então, 86% são preveníveis e, infelizmente, não há evidência que o abuso do uso da colonoscopia de segmento pode compensar uma primeira colonoscopia subótima. Então, infelizmente, no cólon a gente tem lesões muito sutis e, às vezes, essas lesões sutis elas apresentam já uma displasia de alto grau. Por isso surgiram os indicadores de qualidade da colonoscopia, em que a gente deve ter uma preparação do cólon adequada. A maioria utiliza a escala de Boston, mais que 90%, uma intubação secal maior que 90%, uma boa taxa de detecção de adenomas por volta de 25%, a realização da colonoscopia numa taxa adequada e outros fatores. E lembrar que a taxa de detecção de adenomas, ela é a que todo mundo concorda, tem uma concordância de 100% e ela tem uma moderada para alta qualidade de evidência. E lembrar que todo o segmento da colonoscopia, ela se faz baseada na primeira colonoscopia de alta qualidade. Então, a primeira colonoscopia, ela realmente tem que ser de excelente qualidade. Os critérios evoluem. Hoje em dia se aceita uma intubação secal de 97%, uma taxa de detecção de adenoma por volta de 40%, uma preparação de cólon de 95%, um tempo de retirada do aparelho por volta de 10 minutos, ao invés de 6 minutos, e a remoção de 95% dos pólipos, com uma complicação bem pequena. De tudo que a gente tem para aumentar a detecção de adenoma, a gente tem vários acessórios que você pode acoplar. Sem dúvida, o colonoscópio com alta definição, ninguém tem dúvida disso. A retrovisão no cólon ascendente ou a segunda olhada no cólon ascendente é muito importante para a taxa de detecção de adenomas. E depois nós temos a cromoscopia virtual, o terceiro olho, o FUSE, que infelizmente parou um pouco, o GI, o endocuff, endorings, o CAP na colonoscopia, tudo isso aumenta a detecção de adenoma, mas alguns são muito pouco práticos e não são usados. Então, e toda vez que você precisa, no endocuff, endorings, a inteligência artificial ou até mesmo um CAP, você muda um pouco sua rotina. E por isso é que não ter esse uso não é disseminado. O que fica na maior parte dos locais é a cromoendoscopia virtual, que ela, por um clique do botão, você consegue fazer o diagnóstico. E as regras que a gente tem, ou as diretrizes da Sociedade Europeia de Endoscopia, ela sugere que você utilize isso para detecção dos pólipos. E aqui, falando da tecnologia da Fujifilm, o LCI, a gente tem um trabalho, um estudo, uma revisão sistemática de vários trabalhos excelentes. Inclusive, nós temos aqui o Dr. Carlos Eduardo nos representando muito, muito bem, participando do seu estudo desse trabalho, mostrando que você, utilizando o LCI, ele é melhor que a luz branca, ele aumenta a taxa de detecção de adenoma e diminui, então, portanto, o câncer de intervalo. E hoje em dia a gente acha que a luz que a gente deve realizar o exame não é mais a luz branca, é essa luz que você incrementa. Então, aqui, às vezes, uma lesão no seco, uma lesão mais escondida com a luz normal, quando a gente utiliza o LCI, essa lesão fica muito clara. E a gente utiliza muito ainda a classificação de Kudo, que é a melhor classificação de todas, principalmente quando se usa a cromoendoscopia convencional, e isso divide para a gente o que devemos tratar, o que não devemos tratar, eu não vou ficar detalhando. E os Estados Unidos utilizam muito a classificação NICE, mas aqui no Brasil a gente dá preferência também para a classificação do NBI, a JNET, e a JNET, sem dúvida nenhuma, ela veio nos facilitar bastante a diferenciação, principalmente das lesões com invasão superficial, das lesões com invasão profunda, aumentando nossa porcentagem de tratamento endoscópico. De técnicas para retirar pólipos, nós temos inúmeras técnicas. Eu não vou detalhar todas, desde a polipectomia fria a quente, porque nós vamos falar de 90% dos pólipos encontrados no cólon que são menores que 10 milímetros. E a gente já tem os guidelines da Sociedade Europeia, o que a gente deve fazer com esses pólipos. A maioria fala a favor do uso da alça a frio pela Sociedade Europeia nos pólipos pequenos. E aqui num trabalho do Douglas Rex, com Evelyn Decker, publicado na Gastroenterologia Endoscopy, em que 80% então dos pólipos são menores de 5 milímetros, 90% menores que 10 milímetros, e o risco de câncer deles é muito pequeno. E aqui ele faz o que você deve fazer com a maioria desses pólipos. E aqui acrescenta-se se tem displasia de alto grau ou não. Então, quando você faz uma análise com a cromoscopia virtual e se puder fazer uso da magnificação ou do near focus, você pode saber se essa lesão tem alto grau para diferenciar a conduta. Se há suspeita de alto grau, essa lesão não deve ser tratada frio, essa lesão deve ser tratada com mucosectomia. A sociedade americana também, há uma task force da sociedade americana falando praticamente a mesma coisa. A maioria dessas lesões pequenas devem ser tratadas com alça frio, desde que não tenham suspeita de invasão da submucosa. A técnica frio é uma técnica muito simples, só que você age diferente da técnica por exemplo, de uma mucosectomia, em que você, ao prender a lesão, você vai separar ela da mucosa, você vai elevar a lesão. Aqui não, você aprofunda a alça para pegar totalmente a lesão com margem de segurança. Nós temos algumas alças que são chamadas alças dedicadas, que sem dúvida nenhuma elas melhoram muito a nossa ressecção a frio, porque se for fazer com uma alça normal de grande porte de 2 centímetros, por exemplo, você tem uma dificuldade maior e pode levar a complicações. As mais usadas são da Boston Scientific, a Captivator Code, e a da West Endoscopy, a Code Snare. Essas são alças que não passam corrente. A da Olympus já é uma alça que você pode até usar corrente. E por que a alça frio, quando você corta com a alça frio, você tem o corte apenas da mucosa, você não vai envolver a mucosa. E quando você faz uma coagulação mais forte, então você preserva, os vasos estão mais profundos. É simples e fácil e rápida, é aplicável também para as lesões planas, tem menos sangramento do que a alça a quente, e muito pouco risco de perfuração. Então, é uma técnica estándar para as lesões sésseis, adenomas menor igual a 10 milímetros. Lembrar que as lesões 8, 10 milímetros podem requerer 2, 3 pedaços, não tenha problema com isso, faça, não há problema nenhum se a lesão é de baixo grau. Aqui nós estamos citando o Michael Book, que é um dos mestres da técnica chamada Cold Revolution, ele e o Dr. David Hewitt. E então a Cold Snare, ela deve ser a técnica estándar, segundo o Dr. Book, para as lesões serrilhadas sésseis sem displasia de qualquer tamanho. A Cold Snare, polipectomia piscimil, é a técnica preferida, na opinião do Dr. Michael Book, para as lesões de 10 a 20 milímetros planas ou sésseis. E provavelmente para as lesões maiores, segundo a sua opinião. Nos adenomas muito maiores, ele utiliza, mas ele ainda não pode recomendar. Então, aqui só mostrando alguns trabalhinhos rápidos, trabalhos japoneses, desculpa, do Dr. Repice, o trabalho italiano, em que ele avaliou a Cold Snare com o sangramento tardio. E ele mostrou que o sangramento tardio com a Cold Snare é muito, muito baixo e o sucesso na hemostasia é 100%. Aqui o Dr. Yoji Takeuchi me cedeu esses slides que eu achei fantásticos, alguns estudos japoneses, porque os japoneses eles são mais reticentes, eles são mais conservadores. E nesses estudos eles mostram que o tempo quando você usa alça frio é menor e os sintomas após o uso da alça frio são muito menores quando você usa a Cold Snare. Aqui também o slide dele, em que eles compararam os pacientes anticoagulados usando a técnica convencional e a técnica Cold Snare. Eles mostraram que o sangramento tardio com o Cold Snare foi 0, estatisticamente bem significante. Aqui é um trabalho dele mesmo, Dr. Yoji, fazendo com uso de heparina. Num grupo, ele usava ponte para a heparina com a enoxaparina, e na outra ele não fazia ponte nenhuma, ele deixava o paciente anticoagulado e continuava a anticoagulação. E ele viu que o sangramento tardio, que é uma grande preocupação, ainda foi muito menor a despeito da ponte e do que com o uso do hot snare. Então, a sociedade japonesa, que é bastante conservadora, eles estão tentando indicar a Cold Snare para lesões menor que 10 milímetros, não pediculadas e com displasia de baixo grau. E então, os guidelines da sociedade europeia, da sociedade japonesa, para menos de 5 milímetros, eles já recomendam. E de 6 a 9 milímetros, eles acham que é aceitável. E se você tem suspeita de displasia, não está recomendada. As indicações da Cold Snare, essas são os guidelines que estão editando agora de 2020, por isso que eu pedi o slide dele, a gente não tem acesso a isso, que vai sair agora, que é de menor que 10 milímetros e clinicamente com displasia de baixo grau e considerar a ressecção sempre completa. E daí vários estudos mostrando que a ressecção da margem horizontal da lesão é totalmente tirada. Aqui as condutas, e quando ele avaliou a margem profunda, quando você faz o hot snare, às vezes fica o que eles chamam de monumento, fica uma área elevada, esbranquiçada no centro da lesão. E eles biopsiaram após a Cold Snare o meio da lesão, quando você retira e quando você tem essa protrusão e quando você não tem a protrusão. E eles mostraram que a gente tem uma muscularis mucosa nas lesões em 57%, quando você não tem a protrusão em 76%. Então, a Cold Snare, para que todo mundo saiba, ela é bastante superficial. Então, ela não deve ser indicada para as lesões que têm suspeita de displasia. Aqui, estatística de displasia, então, considere a Cold Snare para as lesões de baixo grau. E alguns trabalhos, endossando isso, que ela pode ser adotada, um outro trabalho japonês, sempre todos os trabalhos mostrando que o índice de complicação, quando você compara a hot snare com a cold snare, é muito menor. Então já não é uma questão de opção, é uma questão de uso. Aqui nós não vamos falar, mas só para vocês saberem a polipectomia, aqui nós temos várias opções, vendor loop, clips, para você utilizar na base das lesões, e até a injeção de adrenalina quando o pedículo é curto e espesso, a injeção de adrenalina para que você tenha uma margem adequada é bastante segura. A mucosectomia para tratar as lesões maiores, lembrar que sempre utilizar endoscópio de alta resolução e utilizar corante, senão você vai ressecar essa lesão e quando você utiliza corante a lesão é bem mais extensa do que a gente estava vendo inicialmente. Você vai fazer ressecção incompleta e ter o câncer de intervalo. E daí você consegue tratar adequadamente toda a lesão. Nas lesões pseudodeprimidas, elas têm que ser ressecadas em bloco, porque elas têm uma taxa alta de invasão da submucosa. A técnica underwater, ela também é uma técnica bastante utilizada. O Japão agora está com uma tendência à utilização dela cada vez maior, porque ela mostra que a ressecção em bloco ela é maior do que quando você utiliza a mucosectomia convencional. E é uma técnica muito fácil de fazer para algumas lesões mais difíceis. A lesão realmente ela flutua na mucosa quando você injeta água e fica muito fácil fazer a ressecção com boa margem de segurança. O PCMIL ela é indicada principalmente para as lesões granulares homogêneas e que ela é uma técnica muito boa e muito utilizada no Ocidente e no Japão ela é utilizada, mas o Japão ele tem uma tendência a utilizar a dissecção. A gente acha que tem lesões que merecem dissecção, mas a grande maioria no colo não merece uma dissecção. Algumas lesões realmente têm que ser retiradas em bloco. As complicações, elas não são grandes, mas quando os pólipos são maiores, a chance de complicação é maior. E a perfuração também, se ela é imediata, o tratamento endoscópico, se ela é tardia, na maioria das vezes o tratamento é cirúrgico. O uso de clips para profilaxia do sangramento, ela foi muito discutida e hoje em dia a gente tem vários estudos mostrando, esse é um dos poucos estudos que ele não recomenda, porque ele acha que não funciona muito, mas quando a gente vê estudos multicêntricos, a revisão da literatura, a gente vê que para as lesões maior que 20 milímetros, não tenha dúvida de que a colocação de clipes profilático ajuda. Se a lesão é menor que 20 milímetros, ele não tem influência. Então, já é um dos fatores. Daí a gente tem várias divisões que a gente consegue definir. Então, lesões grandes, maior que 3, 4 centímetros no cólon direito. Aqui eu resumo, pacientes que usam anticoagulantes ou antiagregantes plaquetários, lesões do cólon direito maior que 3, 4 centímetros, que tem mais comorbidades, você deveria fechar com clipe para reduzir o risco de sangramento. E ele realmente é custo efetivo nesse grupo. Lembrar que medicina não é 100%, aqui é uma lesão que a gente retirou PCMIL, ficou bem retirado, a gente nós fechamos a área com clipe, o paciente foi para casa tranquilo, voltou com aqui tirado, peça bonitinha, um sangramento tardio. E aqui o sangramento a gente vê o coágulo entre 2 clipes. Então, o vaso ficou entre 2 clipes, o que nós fizemos, botamos mais um clipe e esse paciente evoluiu bem. Mas lembrar que o clipe não protege 100%. Desculpe o prolongamento e muito obrigado.
Thank you for that beautiful talk. That was really nice. I really enjoyed it, and I'm enjoying this whole conversation. Really, a lot of important information for all of our doctors out there who are performing colonoscopy and polypectomy, and several tidbits that I'll apply to my own practice and share with our team as well. So as we move on, I just want to remind everyone, if you're just joining us, that there is a translate button on the bottom of the little globe where you can switch from English, Portuguese to Spanish. All right. Dr. Oliveira, for your next presentation, for your next panelist, please.
Muito bem. Vamos para o próximo. Vamos chamar o Dr. Kermit, de Porto Rico, que também representa a endoscopia da CIED. O Dr. Kermit vai falar sobre o pós-colonoscopia, né? A eficiência e a sua qualidade universal. Dr. Kermit, com a palavra.
Thank you very much. Gracias. Obrigado. Buenas noches. Good evening, everybody. Thank you for the invitation. I'm really honored that Dr. Asadur, Chekmedian, and the organizers of this meeting invite me. It's a pleasure for me, and I'm really delighted to work with all of you, including Amrita. Yeah, we have worked with Amrita in multiple occasions in our therapeutic endoscopy course down here in Puerto Rico. So it's for me, it's a pleasure to be here with all of you, including Amrita. I just spoke a few minutes ago with Dr. Chekmedian Asadur. He wanted me to excuse him for not being here tonight. He's very, very involved in helping the people from Armenia. And he apologizes for not being here. So my talk is about universal quality and efficiency, with particular attention to the post-colonoscopy phase of the whole procedure. Quality is something that I like very much. I've been talking about quality for a very long time, and I've been invited to several places to talk about quality. And quality, it's very important. We've seen some of the panelists already mention the importance of quality, of a quality procedure in order to prevent colon cancer, which at the end of the day, it's our most important goal when we perform colonoscopies. So why quality is important? Well, because quality produces desired outcomes. So if we do something with quality, we produce the desired outcome. So in the case of a colonoscopy, performing a quality colonoscopy, the outcome is colorectal cancer prevention, particularly in the right colon. Quality matters, and quality colonoscopy prevents colon cancer. So that is basically the reason why quality in colonoscopy matters. Now, quality of care is defined as the degree to which a health services for individuals and populations increases the likelihood of desired health outcomes, is consistent with the current professional knowledge, measured by comparing performance with an ideal or benchmark. Now, what about a high quality endoscopic procedure? Well, high quality endoscopic procedure is defined as a procedure that it's indicated. It's a procedure where correct and relevant diagnoses are recognized and excluded, and any therapy provided is appropriate, and all steps to minimize risk have been taken. So this all started with the task force on quality in endoscopy. In the year 2005, the ASGE and the ACG decided that GIs must take control of quality in endoscopy before some bureaucrat in Washington tells us how to do a quality colonoscopy. So they created the task force, and in the year 2006, they published the first set of quality indicators that were feasible to measure and that were associated with improved patient outcomes. That same year, several articles were published specifically for each and every procedure in endoscopic procedure, including EGD, colonoscopy, ERCP, and EUS, and also an article on common quality indicators for all procedures. This is the base for the transformation in the area of quality. And the last time the task force published these measures was in the year 2015. How do we report quality indicators? Well, the quality indicator is often reported as a ratio between the incidence of correct performance and the opportunity for correct performance, or as a proportion of interventions that achieve a predefined goal. Quality indicators can be divided into categories, or are divided into categories. There is a structural category where, like for example, is the equipment available? Is the equipment receiving the adequate maintenance? Another one is the process. For example, if you biopsy all the lesions that needs to be biopsies. And another category is that of results or outcomes. Like for example, colon cancer development in after screening colonoscopy. These categories can also be divided. I'm sorry, I'm having problems with my technical problem with my slides. They are switching without me doing anything. So you can put these categories into periods: the pre-procedure, the intra-procedure, and the post-procedure. And in the post-procedure is where I'm going to concentrate tonight. However, I'm going to mention briefly the pre-procedure quality indicators and the procedure quality indicators, because that's where most of the quality takes place. Meaning that once you're finished with the colonoscopy, there's very little that you can do to amend for what you didn't do while doing the colonoscopy. So I'm going to briefly mention this. And there are 4 pre-procedure quality indicators. Here they're resumed. As you may see, I mentioned in this table, I have the quality indicator in the left column, then the grade of recommendation, the measure type, and the performance target. Now, for the pre-procedure, you need to take into consideration if the colonoscopy is indicated according to the published guidelines for indications for colonoscopy, that the consent is obtained, that the post-polypectomy and post-cancer surveillance interval is recommended. And I'm going to tell you that this is a priority indicator. And I'm going to spend a little bit of more time in this particular one, even though it's pre-procedure, you will see that it's kind of repetitive because it's also a post-procedure. There are 9 intra-procedure quality indicators that are summarized here. You need to document the quality of the bowel preparation. You need to have an adequate bowel prep in more than 85 of your outpatient examinations. If you don't have that, you need to go back and look at your instructions on how to prepare for a colonoscopy. You need to visualize and make a photograph of the cecum in all examinations and particularly in screening examinations. Also, the adenoma detection rate is very important. You know that it differs for males and females, but it's usually in the neighborhood of 25 to 30, and the higher, the better. So withdrawal time is also a very important quality indicator, and you have to measure and document the withdrawal time, and also most of your colonoscopies should have a withdrawal time of more than 6 minutes. This was already mentioned in the previous topic. Also, the quality indicator is that you have to biopsy patients with diarrhea, in at least in 98% of the cases. Also, make pertinent biopsies or take back pertinent biopsies in patients with IBD, and also attempt to remove polyps less than 2 centimeters before referring the patient for surgery. Now, what about the post-procedure quality indicators? But there are only 3 of them, and they're mentioned here. Number 1, it's the incidence of perforation and post-polypectomy bleeding. First, perforations for all examination shouldn't exceed more than 1 in 500. perforation in screening colonoscopy should be much less than that, about half of that, 1 in 1,000. And bleeding should be less than 1% for this procedure to be considered a quality procedure. Post-polypectomy bleeding also should be managed without surgery. That's another quality indicator. And finally, this is where we get repetitive. The appropriate recommendation for timing of repeat colonoscopy is documented and provided to the patient after the histologic findings are reviewed. Now, this is something that the US Multi-Society Task Force had known for since the very beginning, that was very difficult to measure. Why? Because this is after the patient is already gone. It includes the fact that you have to review the pathology, and then with having the result of the pathology, then you recall the patient in the appropriate interval of time. So it's kind of difficult to measure and to put into practice, but fortunately there are some publications providing some computer algorithms to deal with this automatically and recall the patients automatically by matching the pathology report with the patient after the procedure. So this is where I'm going to concentrate now. But summarizing the quality indicators, you need to take into consideration the bowel preparation. You have to document the bowel preparation. You have to intubate and photograph the cecum. You need to mind your adenoma detection rate. You need to take into consideration the withdrawal time. You need to biopsy pertinent lesions, and you need to plan and schedule the correct interval for repeating a colonoscopy. Out of all this, to remove the polyps, and these are the priority quality indicators. For the purpose of this talk, I'm going to concentrate in this one here, which is the one that tells us what to do after we do a colonoscopy, when to repeat it, and why. So colonoscopy is already done. Now what? Well, we need to provide follow-up recommendations both to patients and to the referring physicians after a normal colonoscopy, after polypectomy, and after resection of colorectal cancer. Now, the Multi-Society Task Force recognizes that this is one of the clinical scenarios where guidance is needed. It's one of the most clinical scenarios where guidance is needed. Why? Because there is a risk of metrakranose neoplasia, and you know that the lower risk is when you don't find any neoplasia at all, and the higher risk is when you find neoplasia. So let's talk about follow-up after a resection of a colorectal cancer. These are the recommendations made by the US Multi-Society Task Force. They were published in the year 2016. And their recommendations are here. The first surveillance colonoscopy is to be done 1 year after surgery or after clearing the perioperative colonoscopy. What does that mean, clearing perioperative colonoscopy? Well, if you have a lesion that is obstructing the colon and you cannot perform a colonoscopy before surgery, you need to do a colonoscopy or a CT colography within the 3 months in the perioperative period. So the first surveillance colonoscopy will take place 1 year after that one. Then you need to do another colonoscopy in 3 years or 4 years after surgery or perioperative colonoscopy. Then you move to 5 years or 9 years after surgery or perioperative colonoscopy. And then every 5 years until benefit outweighed by life expectancy. If these numbers are difficult for you to remember, then remember this number on the right side, on the upper right side, it's 1355. 1355. 1 year, 3 years, 5 years, 5 years. And what if you find polyps in those subsequent colonoscopies or in the surveillance colonoscopy? Well, that is coming soon. I'll tell you in a minute. Now, there are alternatives to colonoscopy, of course. Like I already mentioned, for example, when you have an obstructive lesion, you can do, rather than a colonoscopy, you can do a CT colography. So CT colography is an accepted measure as an alternative to colonoscopy. However, fecal tests like fecal immunotest and the fecal DNA test are not recommended for surveillance. They're definitely not recommended for surveillance. So there are several special considerations for those patients with rectal cancer. Those patients that had surgery without mesorectal excision, patients who underwent transanal local excision, or patients with locally advanced cancer that did not receive chemoradiation and no mesorectal excision, those patients need to be followed with a flexible sigmoidoscopy or EUS every 3 to 6 months for the first 2 to 3 years. And then you take over the recommendations for colonoscopy. I mean, for colorectal cancer, the other ones. Now, what about follow-up after polypectomy? Well, we're lucky that this year, the Multi-Society Task Force came out with a review of the recommendations for follow-up after polypectomy. And they kind of seemed complicated, but I'm gonna run through it. This is the article. It was published in February 2020. I remember this was during one of our meetings down here in Puerto Rico. Actually, Amrita was here, and this was published on a Saturday, and we have Dr. Violeta Popov from NYU talking, and even though they were published the day before, she already put them in her slides and talked to us right away about this. So they were published in February 2020. And basically, the risk of metachronous neoplasia is based on the stratification we do once we perform a colonoscopy and remove a polyp, taking into consideration the histology of the polyp, the number of lesions or polyps, the location, and the size. So once we do that stratification, then we can go and recommend the patient when to come back for a repeated colonoscopy or a surveillance colonoscopy. So I will not mention these areas because this is not contained in this publication from the Multi-Society Task Force. Hereditary colorectal cancer syndrome. So this is published, this is contained in another publication. Same goes for IBD, family history of CRC or neoplasia, and for serrated polyposis syndrome. So we're not going to be talking about that. In fact, the Multi-Society Task Force will make recommendations on serrated polyposis syndrome, malignant polyps, and optimal polypectomy technique in the near future. So we'll be looking forward to that. Now, terminology, it's very important, and this is one of the problems that the Multi-Society Task Force encountered while evaluating the papers for this publication, because the terminology, it's kind of confusing. So there is evidence supporting the level of risk for various criteria, and that we know that this evidence is constantly changing and evolving. So the prior terminology may be confusing, and we need to move to specific findings rather than summary of categories, because this, as I already told you, can be confusing. Like, for example, 1 to 2 adenomas less than 10 millimeters versus low risk adenoma. So it's better to be descriptive, because eventually the data will come out and will let us know what to do with 1 or 2 adenomas rather with other low risk adenoma that has been defined in the past. So this will avoid limiting precise risk stratification. Now, all of this cannot be achieved without quality. So for all the recommendations for the interval to bring a patient back for a surveillance colonoscopy, you have to do a quality colonoscopy. So that is assumed. If not, you need to kind of alter the interval in which you bring the patient back for surveillance. So in summary, a quality colonoscopy should be a colonoscopist should be done with a colonoscopy with an adequate ADR. Those colonoscopists who consistently have a low ADR, they have to intervene and do something to improve their ADR. Dr. Oliveira mentioned several ways in which you can improve your ADR. He mentioned that briefly. Also, that these examination-specific characteristics are met, including cecal intubation, attention to complete polypectomy, and adequate bowel preparation. Now, it's very important out of these recommendations to pay attention to polyp size. Why? Because size determines surveillance intervals. So it's very important to determine the polyp size. So we need to document polyp size with a photograph, especially polyps greater than 10 millimeters for obvious reasons. And one of the recommendations is that you take a photograph of the polyp with an open snare or with an open biopsy forceps to try to calculate the size of the lesion. Now, these are the recommendations based on this a paper out for the US Multi-Society Task Force. First, when you have a normal colonoscopy, 10 years is still there. We're not going anywhere. It's been talked that probably that number will change in the future and probably will go beyond 10 years. But to date, the data for performing this, it's very strong and the quality of evidence is high. So the quality of evidence is very high and the recommendation is very, very strong. Now, if you have 1 to 2 tubular adenomas, small adenomas, less than 10 millimeters, then you can move to 7 to 10 years. This also is a strong recommendation, but the quality of evidence is moderate. And then we go on to 3 to 4 tubular adenomas less than 10 millimeters, 3 to 5 years. And from there on, it's kind of easier because everything is 3 years except for the obvious. The adenomas that are bigger than 10 millimeters on a single examination, then you bring that patient in 1 year. And a patient with a piecemeal resection of an adenoma greater than 20 millimeters, then you bring that patient in 6 months. Now, an adenoma with high-grade dysplasia, remember, even though if an adenoma 3 years in those patients with villous or tubulovillous adenoma, 3 years again is the recommended interval. Now, what about all these hyperplastic polyps, sessile serrated polyps, sessile serrated adenoma, traditional serrated adenoma? What about all this? Well, they did come with a recommendation, but look at the strength of the recommendation and look at the quality of evidence. The only recommendation that is strong is in those patients that has less or equal to 20 hyperplastic polyps in the rectosigmoid area, then you can bring that patient in 10 years. Even though the recommendation is strong, the quality of evidence is still moderate. But for the rest of this, except for piecemeal resection of a sessile serrated polyp 20 millimeters or bigger, then you need to bring the patient in 6 months. That is a strong recommendation, and the quality of evidence is moderate. For all other sessile serrated polyps and hyperplastic polyps greater than 10 millimeters, then the interval is between 3 and 5 years, but the strength of recommendation is weak, and the quality of evidence is very low, meaning that more work needs to be done with this kind of polyps to come with stronger recommendations. Now, these are the key updates since the 2012 guidelines. First, new evidence based on risk of colorectal cancer outcomes rather than based only on risk of advanced adenoma during surveillance is provided to strengthen polyp surveillance recommendations. 7 to 10 years rather than 5 to 10 years follow-up is recommended after removal of 1 or 2 tubular adenomas less than 10 millimeters in size. That is also a key update. More detailed recommendations for follow-up after removal of serrated polyps have been provided, but still the data is not there yet. We will get there eventually. Also, the importance of high-quality baseline examination has been emphasized. And 1 year rather than less than 3-year follow-up is recommended after removal of more than 10 adenomas in one single examination. Also, there is an option to recommend 3 to 5 years instead of 3 years follow-up after removal of 3 to 4 adenomas less than 10 millimeters in size. Now, this Dr. Oliveira also presented this, but this is something that you may print from the article of the Multi-Society Task Force and post it in your endoscopy suite in order to follow these recommendations. And they also put this addendum or appendix to this article where they summarize beautifully the recommendations. And I think that's all I have to say. Thanks for your attention. Gracias. Obrigado.
Excellent talk. Thank you. That was a high quality presentation based on strong evidence. So with that, we are going to continue. We're going to hold off on our question and answers. Just as a reminder, this presentation in its entirety is being recorded, and you could always access it in the future on NYSGE's website. It's now my pleasure to present Doctora Melissa Latorre, who is a rising star in the New York scene. She is the Director of Inpatient Gastroenterology Services at NYU Tisch, and is really doing a fantastic job there as the lead hospitalist. Melissa?
Thank you so much to both societies for inviting me to present. Tonight, I'm going to be discussing complications in colonoscopy, and I'm going to give 2 case scenarios and ask for some input from all of the panelists. So before we begin, it's important to just establish that complications can be really uncomfortable, but it's something that we have to talk about, and we have to talk about our individual experiences in order to help each other and to prevent these issues from occurring. So before I begin, 1, complications will happen, and they will happen to everyone. 2, it's important to put your energy into prevention. An ounce of prevention is worth a pound of cure, or in Spanish, más vale prevenir que lamentar, and I'm sure there's an equivalent saying in Portuguese. But number 3, be prepared, professional, and poised when things go wrong. So next, get your data straight. So this is from the ASGE guidelines on complications. And I pick here the 3 most common the 3 most severe complications that one can experience. So first, perforation with a pooled rate of 5.8 per 10,000 colonoscopies and a very wide range depending on different factors. But usually what we say, the estimate of less than 1 in every 1,000 is applicable here. Next, the most common complication, which is bleeding, and the pooled rate there is about 2.4 per 1,000 colonoscopies. And we'll go into this a little bit more later and discuss kind of the nuances of both perforation and bleeding. And then third, the one that we hope never to experience, and luckily it's very rare, is mortality. So the pooled death rate is about 3 in every 10,000 colonoscopies, all caused within 30 days, 7 in 10,000 colonoscopies. And colonoscopy specific, luckily much less, is 7 in every 100,000 colonoscopies. So moving on to our first case, it's going to discuss a perforation. So I'm going to start with the case of a 60-year-old woman with prior hysterectomy presenting with 6 weeks of intermittent bloody diarrhea and weight loss to a BMI of 18. She has severe abdominal pain. Her CAT scan demonstrates diverticulosis and colitis from the rectum to the transverse colon. She has never had a colonoscopy. So in hearing this history from your patient, I'm already concerned. I'm hearing that this is a woman with prior abdominal surgeries. She has an indication that's going to require most likely a colonoscopy, which is chronic bloody diarrhea for several weeks. And never having had a colonoscopy, it brings to light the idea that maybe this could even be a malignancy. But she also has weight loss with a very low BMI, so I imagine a small frame and a lot of turns. We also see that her imaging demonstrates diverticulosis and colitis. And it's a long segment of colitis from the rectum to the transverse colon. So when we talk about risk factors, and we have to evaluate this for each of our patients, there's different factors that contribute. So you have mechanical factors, and this is the torque, the pressure, the colonoscope size, and even different maneuvers such as retroflexion. You have potential barotrauma, which can be air or carbon dioxide. Then the indication also plays a factor in that therapeutic colonoscopy has a higher risk of perforation than diagnostic. So if you think about polypectomy, or if you're doing this for IBD, there's even a reported 8 times increased risk of complication. Then there are patient factors, so older age being one, gender, female, and prior history of surgeries. There's endoscopic factors where the experience obviously plays a huge difference in whether you're doing this as an experienced endoscopist or a new trainee. And then also being a trained gastroenterologist versus another specialist who isn't particularly trained in gastroenterology as we are, but has the capability to provide the services. So that also contributes into the risk of perforation. And then there are the therapeutic interventions that are done, such as ESD, EMR, APC, dilation, and polypectomy, which are known to be associated with a higher risk of perforation. So taking that into consideration, during the procedure, a pediatric colonoscope, so a colonoscope with a smaller diameter, is used, and carbon dioxide is used for insufflation. So these are 2 decisions that were actively made in this patient scenario to try to minimize the risk of complications. And that's one of the things that I'm talking about with prevention, is how in your individual patient can you minimize the risk. The patient had severe colitis with ulceration and spontaneous bleeding in the sigmoid colon. There was difficulty with advancement of the colonoscope, and manual pressure was used. Medication was given in response to pain. And then the patient was noted to suddenly develop tachycardia and hypotension. So I'm going to ask one of my colleagues here, this is something that we struggle with. I'm going to ask Dr. Oliveira de Santos if he's able to turn his mic back on. Kind of what are the factors that you consider when you encounter a difficult colon? How hard do you try, and what maneuvers might you do in order to minimize the risk of a complication like perforation? Or any of the other colleagues might be able to chime in or jump on.
Actually, at this point, if maybe we can get all of the panelists and course directors on, so we could have a roundtable discussion. But definitely a good presentation here, in that obviously I'm concerned that patient has a perforation. And given the difficulty with, the fact that she has severe colitis and the fact that manual pressure had to be used, and that it was a tough colon, and especially in a very thin patient, I'm clearly concerned for perforation.
And I think to your point, when you ask how hard do you try, that's always the magic question. And what we always teach our fellows in training is, first do no harm. And, the first year fellow tries, or maybe the second year fellow, until the attending comes. And in this case, it sounds like maybe there was a diagnosis made, before you even got to the mid-sigmoid colon.
Yeah, so those are definitely factors to consider. I mean, how desperately do you need to get to the area of interest, and whether you even need to move beyond the area of difficulty. Sometimes it's if you need to really get forward, making the quick decision to change the colonoscope size, or even change to an upper endoscope just to get to the area of need. And really paying close attention to your patient and seeing if their pain is persistent despite increased medication might mean that it's best to abort before developing a complication. So here, this patient, as I mentioned, develops tachycardia and hypotension in the middle of the procedure. So as Dr. Bukovo mentioned, we are concerned about a perforation. And one of the important things to know is that 45 to 60% of iatrogenic perforations are diagnosed during the procedure. So, a lot of the times you're going to see this when you're in the procedure. And so it's important to be mindful of the signs and symptoms, which are abdominal pain or tenderness, tachycardia, hypotension, hypoxia, tachypnea, severe distension, and even tensionpneumoperitoneum. And to be mindful of endoscopic visualization of the mucosa and potentially a viscera if you've created a perforation. So one of the safety and on the spectrum of prevention, one of the tips that I often give, and that's part of our personal timeout at NYU, is to do an abdominal assessment at the start and at the end of the procedure to feel the patient's abdomen, to make sure that you understand any differences. And of course, there's sometimes more air at the end of the procedure and distension, but you can definitely tell if there's a tense abdomen if you do an exam before and after. So moving on to the locations to be mindful of, the locations of iatrogenic perforation, the most common area is in the rectosigmoid, and that's exactly where we were in this particular case, where our patient began to develop symptoms. So here we have our complication, and as you can see, there's a background of colitis, and then all of a sudden there's this hole, and then if you look beyond, you may see some of the internal organs. So what information do we have on managing? And I got this article from the World Journal of Emergency Surgery, which really had this great flow chart on how to handle this scenario. So in the setting of an iatrogenic colonoscopic perforation, it's important to distinguish that you're in there with the colonoscope and you're in there during the colonoscopy versus after. So in this scenario, we're in there during the colonoscopy and able to see what's going on. And here, on this expert consensus panel, they say a perforation less than 2 centimeters with low intraperitoneal contamination, which you hope will be the case if your patient has appropriately consumed their preparation and cleaned their colon, may be amenable to endoscopic closure. So the reality is that it's important to move quickly before you start blowing air into the abdominal visceral space, and to identify this early so that you can achieve endoscopic closure. So they also recommend afterwards, or you can even start this during the procedure, starting IV hydration, making sure your patient has appropriate venous access, giving antibiotics, and in this case, even making sure that you're on the appropriate insufflation, or maybe even just shutting that off and using water to be able to evaluate and do endoscopic closure. Now, if the lesion is large and not amenable to endoscopic closure, it's important at that point to consider an emergent surgery for further evaluation. The contrary, which is not the case for this scenario, is after colonoscopy, where your patient may come in once the procedure is completed. And there you're going to require, high clinical suspicion, and you're going to have to work closely with the team that's going to see your patient before you, because you're not going to be the first one. It might be the emergency room, it might be the medical or surgical team, and get the appropriate imaging and do the appropriate exam to determine what the diagnosis is. So, just taking a second here, I'd like to talk about endoscopic closure and maybe open it up to see what are some of the preferred techniques or expert tips for endoscopic closure, whether standard clips or if anyone wants to discuss experience with over-the-scope clips or other modalities.
I think the role for endoscopic clipping is definitely useful if you're able to see it, as you had pointed out in your picture. If you're able to find the perforation, I think it's worthwhile, and as this algorithm has shown, especially with an over-the-scope clip. But I would caution you in this particular patient where you have colitis, and as one of the attendees had pointed out in a comment, they mentioned that the problem here is the ulceration, that the ulcers are friable, and that in this case, maybe the procedure should have been avoided when the severity of the ulceration was noted. So I would caution that as you attempt to clip in this particular patient, that it may lend to further harm rather than fixing the problem. But absolutely in a perforation, if it's not in an area of ulceration, I would absolutely attempt it.
Yeah, I mean, I definitely agree. I was leaning towards the diagnosis of inflammatory bowel disease, maybe an ulcerative colitis here. So surgery would definitely be the preferred scenario if it was in an area of deep ulceration. And so the other part of this to recognize when you're working around against the clock in some ways for endoscopic closure is to monitor very closely for the development of tension pneumoperitoneum. So it can be a difficult diagnosis in that, when you have the perforation, you can see hemodynamic changes, but, with the tension portion, you're going to see a sudden collapse in intra-abdominal aortic pressure and hemodynamics. And so one of the challenges is really knowing when to make that move and when to emergently take that angiocath and just put it in the abdomen. And so I think once you start to see that hemodynamic compromise and it's starting to become an emergent situation, the abdomen is very distended, it's better safe than sorry. And so the technique for that and the management of tension pneumoperitoneum, and you can imagine the chaos in this moment in time within your endoscopy unit if it hasn't happened to you, is to, again, remember to obtain a large bore angiocath. Remember to put the patient supine so that air can rise. If you have an antiseptic on hand, definitely put that on. And then insert the catheter, and I think this kind of makes it a little bit easier to remember, in the areas where you might insert a paracentesis needle. Whether it's 5 centimeters medial and superior to the anterior superior iliac spine on either side, or 2 centimeters below the umbilicus at the linea alba, are generally some of the preferred areas. Again, remembering that air is going to rise, so that should help you. And hopefully, this will be able to buy you time for the patient to recover hemodynamics and get to their next area of management, which would at this point likely be surgical. Any other thoughts from anyone, or anyone actually have to do this?
Hey, Melissa. I mean, in when we do things like with third space, obviously this becomes a routine, and it's sometimes nice to be around it to sort of watch how calmly it can be done. I'd go back to the one comment I would say about the clips that you would use, or when you're thinking about your next step, is thinking about how long it took you or how difficult it was to get to that place. If it was a really difficult colon, then you make a decision to use an over-the-scope clip, which means coming out and then having to go back in. That means more insufflation, more chance for fecal contamination. So on the right side, you might go to a through-the-scope clip a little bit more quickly, at least as an initial maneuver, versus the left side where it's pretty close. And then the other thing is just remembering, is the colon spastic? How is the prep? How easy will it be able to visualize your location? And in fact, think about marking the location so that you can easily identify it if you do, for example, have to go back with an over-the-scope clip.
Yeah, those are all really great points. I'm not sure, I think over-the-scope clips are becoming much more prevalent, and people are now more comfortable using them. Even, I think, there's some thought that this was more of an advanced endoscopy device, but it's if you're comfortable with a bander, it's a very similar technique and kind of mechanism to use. So it's a translatable skill, and in these emergency situations can be really effective. And so in this case, the patient was diagnosed with a 1 centimeter colonic perforation. It was small. The colonoscope was withdrawn and air was suctioned out. Antibiotics were started, and the defect was closed with an over-the-scope clip, presumably not in an area that was deeply ulcerated, but enough to be able to be mended. And the patient was later diagnosed with ulcerative colitis and managed to avoid surgery. So moving on to our next case, and this is the bleeding scenario. So as I mentioned, this is really the most common complication that comes with colonoscopy. And on my week on call last week, we had 2 post-polypectomy bleeds, and it's really a common scenario when you're working in the hospital. So the history on this case is a 70-year-old man with coronary artery disease on aspirin and atrial fibrillation on anticoagulation. He is undergoing surveillance colonoscopy. He has a family history of colorectal cancer in his mother and a personal history of advanced adenomas. So you have somebody who's still within the screening range, but with some, cardiac and cardiac issues that require anticoagulation. But given his family history and his personal history and his general, well-being, he's not critically ill and he's doing well for himself. It's important to continue screening and surveillance in this patient, and for him to undergo his colonoscopy, and for us as gastroenterologists to minimize his risk of complication as best as possible. So going into this scenario, you want to weigh, again, the risk factors, the different factors that can contribute to complications of bleeding. So again, there are patient factors, and some of those patient factors being age, and this is an elderly patient. He has cardiovascular disease, another factor also being renal disease, and he's on antiplatelet and antithrombotic, and with, I didn't specify which anticoagulant, but something there. Of note, I did not mention that he had a history of stroke, so he has no history of stroke, so the anticoagulation can become a little bit more modifiable. So when it comes to antiplatelets and antithrombotics, there is a whole ASGE guideline on this topic, and I really, really, really encourage you to know when to stop, when to bridge, and when to continue medications. And it's really important, and as the different types of medications and different combinations of medications get more complex, it's really important to know which ones are essential, which ones can be held, and when can they be restarted in order to really minimize the risk of post-procedural bleeding, and to discuss these with your patient. Next is in the specific scenario of polypectomy, and polypectomy being one of the main risk factors for bleeding following colonoscopy. There's factors such as the size of the polyp, the number of polyps removed, the histology, and the location. So the bleeding risk increases almost 2 to 4 times when there is a polypectomy. And there's a 13% increased risk in bleeding for every 1 millimeter increase in polyp size. So that's pretty impressive, considering that our estimation of polyp size is non-precise. But there's a pretty big risk associated with a 1 millimeter increase in size. And certain types of polyps, such as Poitsier polyps, tend to have more vascular component to them. And for whatever reason, location on the right side is also associated with a higher risk of bleeding, whether it's because there's more flat lesions, etc. But these are also factors which, if you know them going in or you know the patient's history, are something that you may account for in terms of assessing or discussing potential risk of bleeding. And then there are also, endoscopist and procedural factors depending on the technique. One thing that we know is that, hot snare polypectomy is associated with more delayed bleeding and cold snare with more immediate procedural bleeding. The other factor when it comes to therapeutic or procedural risk of bleeding is to note the procedures that are higher risk for bleeding and those that are lower risk. So again, this is another table from the ASGE guidelines, which I find really helpful, not only for colonoscopy, but for all procedures, that tells you, what's high, what's low, what can be done on anticoagulation, or what needs to be modified. So diagnostic tests are usually okay, even including biopsy. But once you start moving to polypectomy, there is a concern that there's a higher risk of bleeding. And I know Dr. Oliveira mentioned some of the factors that were considered in terms of smaller polyps, and that's also something to take into consideration. But this is kind of a general guideline in discussing with your patient. So moving on with the procedure, the patient's anticoagulation is held. And this decision, again, to continue or to hold anticoagulation or antiplatelet should be made in conjunction with the prescribing physician or the expert, whether it be a cardiologist or a neurologist, just to make sure that everyone is on the same page about this decision. And the risks on both sides, the risk of holding something and the risk of continuing it, should be discussed with the patient. Then during the colonoscopy, the patient is found to have 3 polyps. So an 8 centimeter, that was supposed to be millimeter, 8 millimeter sessile polyp in the transverse colon removed with cold snare, a 15 millimeter pedunculated polyp in the sigmoid colon removed with hot snare, and a 25 millimeter flat polyp in the ascending colon removed with EMR. So prophylactic clips are placed on the EMR lesion, and the patient is told to restart anticoagulation at discharge. 1 week later, he returns with blood per rectum. So in discussing the post-polypectomy bleeding, we mentioned that there is the concept of early bleeding within less than 24 hours, or even procedural bleeding, and then delayed bleeding, anything from 24 up to 14 or even 30 days afterwards. Early bleeding usually more likely associated, or procedural bleeding, with cold snare, and delayed with the use of cautery. So this was touched upon before, but for thoughts on prophylactic clipping. It's not effective for smaller polyps, and there's different, a little bit of mixed data out there. But one larger study showing, despite the use of antithrombotics, prophylactic clipping isn't necessarily effective. Where it is effective is for delayed bleeding in non-pedunculated large polyps greater than 2 centimeters in the proximal colon. So that's where our patient's polyp was, and he had the prophylactic clipping performed there. There is also discussion that the use of epinephrine before may reduce procedural bleeding, but not delayed bleeding. And finally, there is this gray zone of kind of prophylactic clipping. And, the question that comes to mind is, how hard was it to get there in the first place? And I guess, you know, one of those factors being, how much risk did the patient undergo to have the procedure done? And, you know, do they have a large cardiovascular burden? Did they have a tortuous colon? And if you had to go back there in worst case scenario, what would that be like? So I guess, you know, these are the recommended guidelines, but I wanted to get some insight into, from the panel here on some of your experience and some of the things that you might do, and you know, scenarios that are outside of this box, like perhaps patients that are on multiple agents and not just one, or you know, your thoughts.
Well, that was a very good analysis about what happened with this patient. I just wanted to briefly mention, for those of you who attended the virtual ACG, in the postgraduate course, there was a beautiful lecture presented at the very beginning of the course, and I looked it up here. It was presented by Dr. Nina Abraham, and the lecture was entitled Gastroenterology, Intersectional Thinking to Meet New Clinical Needs. And it was precisely about this problem that we encounter much more commonly every day, of patients being anticoagulated and not knowing what to do and what the risk is about for possible bleeding if we restart the anticoagulation the very same day. The bad guy, it's probably Plavix together with aspirin. And I think, if I'm not mistaken, she mentioned that the good guy, it's probably apixaban. Apixaban, yeah. And because the risk of bleeding turns out to be less. And she mentioned a lot of things in this lecture, because there is a very, very big intersection between what the cardiologists are doing and what we are doing with our patients, and what they are doing by poisoning these patient platelets, as a friend of mine used to say. They poison the platelets, and then we have to deal with the problems. So I just wanted to mention that.
Yeah, and I think, again, it's really important to make these, to use a shared decision-making approach to this, to talk to the patient's cardiologist, to talk to the patient's neurologist if it's for a stroke indication, and also to incorporate the patient and say, this is what's going to happen on both sides of the coin. Because bleeding, as we know, is as we mentioned, is the most common complication. So with that said, the outcome of this case, the patient was found to have a hemoglobin drop of 3 grams per deciliter, was admitted to the hospital. He underwent repeat colonoscopy, and the previously treated 15-millimeter polyp was found to have a visible vessel. Now, this was the polyp that was not prophylactically clipped, because it was per se not indicated, but it was a hot snare lesion. And that vessel was treated with submucosal epinephrine and clipping. The other 2 polypectomy sites were well healed, and the patient was discharged on their anticoagulation and sent home thereafter. So some other controversies, and I really thought about this when, again, this patient came through the emergency room last week at my hospital, but the question of like when to admit or not to admit, how much blood does a patient have to report in order for you to be concerned? And, you know, a lot of times you have the patient come in soon after their procedure, and they're like, oh, but I just had, you know, I only had a soup and a sandwich. And, you know, do you re-prep? Do you not re-prep the entire colon to make sure you have adequate visualization, or you just kind of go in and kind of go in sooner to be able to evaluate what's going on in more real time? And then when you have this scenario of multiple polyps that perhaps multiple hot snare polyps, you know, what do you treat, and how might you treat it? And then what do you do? And we touched upon this, and I do agree that Dr. Abraham's lecture. I heard it myself in various forms, also as a Grand Round speaker. But she really gives an excellent discussion on gastrocardiology and kind of thoughts to and approaches to these medications. So we can direct everyone to that just in the interest of time, but perhaps some thoughts from our colleagues on these possible controversies.
Always a tough decision to make with regards to these controversies, and I have to say it is tough managing these patients. There's nothing more. I often will tell a patient it's much easier for me to treat a bleed than to treat a stroke, especially if somebody comes in with a serious stroke and has lifelong repercussions. I almost feel that we can treat that bleeding, but it's really a difficult scenario. But we are encountering this more and more. So usually minimize holding any antiplatelet or anticoagulants for the shortest period of time possible, and prophylactic clipping when indicated, but there will ultimately be bleeding. We are pretty good, or really good, at managing these bleeds. And again, I'd rather see somebody to be able to successfully treat a bleed than a stroke or a massive MI from intrastent thrombosis.
And there's also not much of a choice. You have a 70-year-old man with a family history of cancer, adenomatous polyps. You expect to live at least another 15 years or 20 years maybe. So you can't leave the polyps alone. And a question came in through the Q&A about whether to do this procedure as one session or two sessions and remove one polyp at each session to figure out, maybe which is the bleeding lesion. But I think that's where the gray zone that you referred to comes into play. That requires a lot of work on the patient's part, prepping twice, stopping his anticoagulation, restarting the anticoagulation 2 times. So personally, I would try to get it all done at the same time as you did. And like Juan Carlos said, we're very good at managing this bleeding. As long as you have good rapport with your patients, the patients can reach you in your office, and obviously that's very important as well.
Yeah. So I think, I agree. These are hard questions that we have to ask ourselves. When a patient comes through, the first question that I try to ask myself is, well, are they on antiplatelet or are they not? And if they are on antiplatelet, I try to be, or any anticoagulant, I try to be more aggressive about it, because I know they're more likely not going to tolerate any ulceration or post-polypectomy site if there is already manifesting with bleeding. And then if I go in and there's an obvious lesion, then I'll attack that one. If there's one that's actively bleeding, if there's one that has very visible stigmata. But if they're all kind of just clean based and the patient was bleeding, then, I think it's, in some cases, you just clip them all just to make sure that they can safely go back on their anticoagulant if there's no obvious, culprit. But, I always, the patients, I think the hardest part is to convince them to prep again, but I like to make sure, and I tell them, this is for me to make sure that I'm going to do this right, and we're going to see everything, and that we're going to resolve this issue. And the majority of the time they can get by with that reassurance. So seeing the other side of it as an inpatient only provider, that's kind of how I see. But I always wonder, not the thoughts that everyone has, since there's not really much evidence on this, on how to manage this issue for hospitalized patients. So
I want to make a comment on that. When I did my fellowship training, I was taught by one of my attendings to prep the patient the moment they step into the emergency room. And that is the way I've been doing it for years. And whenever I get a call from the emergency room that somebody came bleeding after polypectomy, that's the first thing I do. And if you look into the data, there is basically no data to support that, to my knowledge. So, but that is something that it's customary for me to, when I get a call, a patient's bleeding, to start immediately.
So, yeah,
eu gostaria só de fazer um comentário assim. A gente aqui, eu tenho, a enfermagem faz uma pré-triagem quando o paciente é eletivo. Então a gente sabe já previamente se ele faz uso de anticoagulante ou não. E daí a gente faz uma carta para o médico que prescreveu o anticoagulante, se ele pode parar ou não. Se ele não pode parar, daí o que a gente faz eu uso, principalmente se o paciente for idoso, com comorbidade, aí eu tenho um uso de clipe muito mais frequente. Se ele pode parar um anticoagulante, daí eu ajo normal. Se a lesão é grande de colo direito, eu uso clipe. Se é do lado esquerdo, eu não uso clipe. E lógico, se tiver algum sinal após minha ressecção que ele mereça usar um clipe, que tem um vaso muito proeminente na base, que não, eu utilizo o clipe. Então, assim, é uma conduta, eu sei que a gente vive numa zona cinzenta, mas é subjetivo, mas eu acho que essa pré-consulta da enfermagem, e toda vez que usa anticoagulante, ela traz para o médico para ver o que fazer com esse paciente, porque hoje em dia tem inúmeros anticoagulantes e até normas que a gente tem que pesquisar para poder suspender ou não, pedir a suspensão ou não. Então, eu acho que, mas é complicado. Agora, eu só queria falar no outro paciente da perfuração, o que a gente faz frequentemente, mas só uma conduta individual, o paciente, a gente vai fazer uma colonoscopia e essa colonoscopia está difícil em algum lugar, a primeira coisa que eu faço é virar para decúbito dorsal. E porque daí você pode, eventualmente, no abdômen, ver que tipo de alça que está fazendo, principalmente se o paciente for magro. E então a gente previne, assim, às vezes, alguns casos que poderia ser uma perfuração. E se mesmo nessa posição continua muito difícil e você continua formando muitas alças, às vezes o que a gente faz é raro, mas é suspender mesmo com o uso de pediátrico. É só o que eu queria acrescentar, mas é muito pessoal.
Yeah, I think those are all really great points. And, you know, again, a lot of it experiential, since we don't have, you know, when it comes to the patient in front of you, they're not always reflective of the literature, the data that's out there. So thank you for sharing that, Dr. Oliveira. And the other quick point that I wanted to make is, you know, trying to guess which one the lesion is that's causing the culprit. A lot of the times we go back to, you know, when we talked about risk. So usually more likely on right-sided lesions, larger lesions, and lesions where there was a hot snare used or heat, in that the defect that comes from the electrocautery can sometimes be larger in the post-procedural time due to ischemia of the tissue than it was when you left the colon. And so sometimes you'll go back and you'll see that that defect was a lot larger than what you remember the polyp to be. So with that said, again, in conclusions, complications will happen. Please be prepared in advance. And I liked Dr. Sethi's suggestion of observing people who work in the third space and to see how this is managed, where it's, you know, expected when you go in and do certain procedures to have a perforation that's going to need to be repaired, so you feel comfortable in a controlled environment. Discuss all outcomes with your patient and document your discussions, you know, when you do your notes in the your pre-procedure notes, that you've said these are the potential outcomes, these are the potential complications. If a complication does occur, remain professional and poised. Of course, your energy is going to transmit to all of the people around you, and whether that's your staff or the patient themselves or their family. And you know, as hard as it is, when you have a complication, it's important to continue to communicate with your patient and be empathetic, whether you're embarrassed or whether you're upset personally or whether you feel disappointed, whatever the emotion may be, continue to communicate with your patient. If it was not your own complication, communicate directly with the proceduralists and reach out to them, just to let them know as a courtesy. And then most importantly, and for our last patient, I think this sometimes kind of gets lost, a message gets lost, but if a patient has experienced a complication, even if it was anticipated, they may be reluctant to get that next colonoscopy. And as we established, our patient in this case definitely needed this colonoscopy with the family history and the personal history of adenomas. But remind your patient not to be deterred from colonoscopy in the future, and that, again, you'll work together the next time to minimize the potential for complications. So with that said, thank you, gracias, and obrigada.
And with that, I'd like to thank everybody for joining us this evening. I know we went overboard, but there was really some overtime, but there was really a wealth of information and this beautiful collaboration between both of our societies. I want to once again thank Nestle Health Science. I want to thank all of the speakers tonight for their contribution, their time, and the panelists, the course directors. I'd like to put a little plug for our upcoming course for the NYSGE 44th annual course. Hopefully you can join us. It's going to be a virtual event with a lot of excellent speakers and panel discussions. And good night. Boa noite. Buenas noches.
Buenas
Buenas noches.
Boa noite. Obrigado.
Bom, boa noite. Foi um evento fantástico. Tenho que agradecer a todos os apresentadores, agradecer a todos os coordenadores do curso. Colonoscopia é um tema muito apaixonante, por isso que estamos com tanto tempo de discussão e certamente ficaríamos outras 2 horas. Espero que seja apenas o primeiro evento, tem muitos outros que virão por aí. Um agradecimento especial à Anrita e ao Assadur, que são os mentores deste evento. O Assadur, para quem não conhece, é o nosso presidente da CIED, uma pessoa muito ativa, aliás, proativa, e que certamente estaria aqui, se assim pudesse. Ele tem uma descendência armênia e todos nós sabemos as dificuldades que o seu país está passando, e ele está envolvido em toda essa situação. Mas certamente ele está muito orgulhoso, não só do evento, como dos representantes da CIED que aqui estiveram. Muito obrigado e boa noite a todos e até a próxima.
Thank you very much. Night.
Obrigado.
Tchau, tchau.
Tchau.
When you're down in trouble and you need some love and care, and nothing's going right. Close your eyes and think of me, and soon I will be there to brighten up even your darkest night. You just call out my name, and you know wherever I am, I'll come running to see you again. Winter, spring, summer, or fall, all you have to do is call, and I'll be there. You've got a friend. If the sky above you grows dark and full of clouds, and that old north wind should begin to blow, keep your head together and call my name out loud. Soon you'll hear me knocking upon your door. You just call out my name, and you know wherever I am, I'll come running to see you again. Winter, spring, summer, or fall, all you have to do is call, and I'll be there. Now any